Listening test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for extract 1.
Extract 1. Questions 1 to 12. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
You hear a doctor talking to a patient.
Good morning, doctor.
Good morning. Tell me about your problem.
I am having severe and recurrent jaw pain, doctor. There's also numbness and tingling along the jaw, teeth, and tongue.
How long have you had these problems?
For the past 6 months, I even consulted a dentist, but the dental evaluations are normal. I was also diagnosed with a throat infection last week, and I was prescribed Avalox, which I've almost completed. I am taking cough drops and trying to increase fluids.
Oh, I see. Do you drink or smoke?
No, doctor, but I used to chew tobacco for about 30 years, but I've recently stopped.
Okay.
Moreover, I've also lost the sensation of taste. The numbness is on the left lateral tongue and jaw that extends from the angle of the jaw to my lip, doctor. Recently, I've gained about 20 pounds of weight, and that may be due to decreased activity.
Do you get headaches?
Yes, doctor, about twice in a month.
Do you experience any fever or chills?
No, doctor.
Do you have any tooth pain, especially while biting?
No, doctor.
Have you had any jaw popping?
No, doctor.
Any spasm of the jaw that is trismus?
No, doctor. I've stopped chewing tobacco, and I'm using Nicorette gum now, doctor.
Okay. What's your age now?
50 years.
Have you ever had any surgery?
Yes, pertinent for hernia repair surgery.
What medications are you taking at the moment?
Tylenol, and I'm on Nicorette gum.
Are you allergic to any medicine?
Yes, I'm allergic to codeine. I used to feel dizzy or lightheaded when I took codeine.
Your blood pressure is 138/82, pulse 64 normal, temperature 98.3, and your weight is 191 pounds. Your oral cavity is normal with good moisture. You have a slightly decreased sensation to your left jaw that extends to the left lateral tongue and left intrabuccal mucosa. The fiber optic nasopharyngoscopy reveals a moderately deviated nasal septum to the left, large inferior terminates. You have developed persistent paresthesia of the left manual teeth and tongue, possibly neoplasm within the mandible. You have also developed hypogeusia with loss of taste and dry mouth syndrome called xerostomia. I would suggest you have a CT of your head, including sinuses and mandible, so that I can evaluate and make sure you have not developed neoplasm. Take plenty of fluids and come and see me again when you get your diagnosis reports.
Extract 2, questions 13 to 24. You hear an osteopath talking to a patient called Joe Parr. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Now, Mr. Parr, I can see from your GP's notes that you've been experiencing some unusual symptoms recently.
Well, yes, that's right. You see, it's come on gradually over the last few months. The pain, that is. It began in my hips and it slowly got worse. It soon spread to my lower back, mostly on the right side. I thought I'd just been working too hard and a good rest would sort things out, but I actually find it the opposite. It's much worse after I've slept and it actually feels better following a bit of exercise, which is hard to understand.
And is the pain still there in your back?
Yeah, but not only there, it's now pretty widespread. Makes me rather moody, to be honest, which isn't like me, because it's now on both sides and it's gradually gone into lots of different areas, like my shoulders.
Okay.
What's most annoying is it now hurts to walk sometimes, because it's even in my heels now, at the back of them, here. It's really quite tender.
I see. That must make things difficult. And have you noticed any other symptoms apart from the pain, I mean?
Well, I'm tired an awful lot of the time, and something strange I have noticed just recently is my eyes. I've noticed they feel pretty sore for some reason, and they're watery, too. And sometimes I can't really see properly. Things look quite blurred. I've lost my appetite, too. I just don't feel like eating half the time, and I used to be a really good eater.
And looking at your GP's notes from your last appointment, I see that she sent you for some blood tests?
That's right, and she told me the first one showed I had mild anemia.
Okay.
That could be why I've felt so tired these last few months, I guess. She said that the following test showed some inflammation, too, which she said was in the bowel. I think that might explain the loss of appetite.
And have you found anything that helps with the pain?
Nothing makes it go away for any length of time, to be honest. Though I do find that heat often soothes it, you know, heated pads and warm showers. But the pain always returns soon afterwards. Something which does seem to help a little is yoga. A friend of mine teaches it, so she showed me a few exercises to do. I mean, it doesn't get rid of the pain, but it seems to ease it. She suggested acupuncture too, which I tried, but I gave up after a few dozen sessions. It just wasn't making any difference at all. That was disappointing because it was quite expensive, actually. The same friend's just lent me her TENS machine, so I've started using that. It's a funny sensation, you know, the pads on my skin. And I'm not sure if it really helps or not, but I'll stick with it for the moment.
I see. And what about your family? Does anyone else have the same sort of problem?
Not that I know of. I mean, I'm an only child, and my dad died about 6 months ago. He had advanced lung cancer. And my mum's pretty well overall. She even helps out sometimes with my work admin, which I really appreciate. I'm a plumber. I work for myself, and she knows how difficult it's been recently with this pain. It's affecting me quite a bit, to be honest. I mean, I still try to see my friends every weekend. We used to go 10-pin bowling, and I enjoyed that, but I don't go anymore. I can't seem to concentrate very well these days when I'm doing anything like that.
That is the end of Part A. Now look at Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now, look at the question 25. You hear a discussion between a doctor and nurse about different complications following heart attack.
Hello, doctor. What types of complications are expected following heart attack?
Well, there are two types of complications that can occur following a heart attack. The first problem occurs pretty much straight away, and the second complication occurs later on. Immediate complications following a heart attack are arrhythmias is the immediate complications in which the heart beats irregularly, either too fast or too slowly. Cardiogenic shock is when the patient's blood pressure drops suddenly. Therefore, the heart cannot supply adequate blood for the body to function properly. Hypoxemia is the condition when the oxygen levels in the blood become too low. Pulmonary edema occurs when the fluid accumulates in and around the lungs. Deep vein thrombosis occurs when the deep veins of the legs and pelvis develop blood clots that either block or interrupt the flow of blood in the vein. Myocardial rupture occurs when the heart attack damages the wall of the heart. That has an increased risk of a heart wall rupture. Ventricular aneurysm is when a heart chamber called a ventricle forms a bulge. Question 26. You hear the discussion between two doctors about the impacts of acute kidney injury.
What are the impacts of acute kidney injury, doctor?
Acute kidney injury is a common and severe complication of surgery, especially cardiac surgery. Often, the complication is associated with higher rates of morbidity, mortality, and cardiovascular events, longer hospital length of stay, and higher cost. During stage 1, there will be an increase in serum creatinine of 1.5 to 1.9 times baseline, an absolute increase of at least 0.3 milligrams per deciliter, or urine output of less than 0.5 milliliters per kilogram per hour for 6 to 12 hours. During stage 2 of acute kidney injury, there will be an increase in serum creatinine of 2.0 to 2.9 times baseline, or urine output less than 0.5 milliliters per kilogram per hour for 12 or more hours. During stage 3 of the condition, there will be an increase in serum creatinine of 3 times baseline, an absolute increase of at least 4 milligrams per deciliter, initiation of renal replacement therapy, urine output less than 0.3 milliliters per kilogram per hour for 24 hours or more, or anuria for 12 or more hours. Question 27. You hear a discussion between two doctors about acquired melanocytic nevi.
Hello, doctor. What are acquired melanocytic nevi?
Acquired melanocytic nevi are clumps of melanocytes that originate during childhood but manifest during 30 to 40 years of age. Junctional nevi form macules, with the skin markings becoming slightly more prominent. They are circular flat lesions with a uniform brown coloration. They have lentiginous cells, which are round or oval or spindle-shaped. Dermal nevi are raised pale brown or skin-colored lesions, and often hairy, having focal globules and fine vessels or pale areas. Pseudohorn cysts may be seen. The cells are epithelioid with amphiphilic cytoplasm, and the melanin is in granules. Compound nevi may be raised with a wart-like surface in certain cases and are usually lighter brown than junctional nevi are. They have round or oval globules of pigment, and these may form cobblestone patterns. Question 28. You hear a discussion between a doctor and nurse about amblyopia.
Hello, doctor. Can you explain what is an amblyopia?
Well, amblyopia is the medical term for lazy eye that refers to a condition in children where the vision in one eye fails to develop adequately. This usually affects the ability of the child to see using the weaker eye. In strabismic amblyopia, a squint develops due to a mismatch between the muscles that support the position of the eyes. Therefore, the brain ignores the eye that is not straight and relies on the images generated by the stronger eye. In a condition called anisometropic amblyopia, the refractive error is greater in one eye than the other eye. Therefore, the brain ignores the more farsighted eye and relies instead on the eye that provides a clearer picture. However, the weaker eye remains straight. Therefore, the defect may go unnoticed by the parents or primary care doctor. In the condition called deprivation or occlusion amblyopia, one eye is deprived of vision due to the development of a blockage, such as a cataract. The ocular media becomes opaque, preventing visual information from reaching the brain. Question 29. You hear a discussion about miliaria.
Hello, doctor. What is miliaria?
Well, miliaria is the conditions associated with sweat retention in the skin. When the flow of sweat is obstructed, the sweat stays trapped within the skin instead of moving out from the sweat glands to the surface of the skin, developing various symptoms and signs, including skin lesions. Miliaria crystallina, also called pseudomina, describes sweat duct obstruction in the uppermost epidermis, where the sweat is retained to form subcorneal vesicles. These clear, non-inflamed, fluid-filled blisters and papules rupture easily, and even light rubbing can cause them to break. Miliaria rubra, also called prickly heat, and refers to the retention of sweat that moves into the middle layers of the epidermis and the upper dermis, resulting in itching and redness around the sweat pores. Miliaria pustulosa occurs when the miliaria rubra develops as inflamed pustules. Miliaria profunda occurs when the sweat moves from the ducts into the dermis. Hard, flesh-colored, painful papules develop that are much larger and more deeply located than the papules seen in miliaria rubra. Question 30. You hear a lecture about different type of stents. We see today what is stent and what are the different types of stents. Stent is a splint that is placed inside a duct, blood vessel, or canal temporarily to aid healing or relieve an obstruction. Primarily, they are used to keep narrowed blood vessels open and patent, to allow sufficient blood flow or bodily fluid. Coronary stents are a tubular, mesh-like device that do not have any embedded medications in them. Drug-eluting stents are coated with medications to prevent inflammation and retinosis of the artery on a long-term basis. A urinary stent is used to hold open the ureter in cases where it is narrowed. Ureters are long tubes that carry urine from the kidneys to the bladder, where it is stored until it is emptied. Urethral and prostatic stent is used to open up the narrowing caused by an enlarged prostate pushing against the urethra, preventing the normal outflow of urine. Peripheral vascular stents are used to keep blood vessels outside the coronary arteries open. Stent grafts are tubular devices made up of a special fabric that is supported by a rigid metal stent. These are mainly used for vascular surgeries, such as to repair abdominal aortic aneurysm. Stents can also be used to keep the food pipe of the esophagus open in case of esophageal constriction, and biliary stents can be used to maintain adequate drainage of bile into the intestine. That is the end of Part B. Now, look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now, look at Extract 1. Extract 1, questions 31 to 36. You hear the discussion between a senior doctor and junior doctors on epidermal nevi. You have 90 seconds to read questions 31 to 36.
Hello, doctor. Can you please explain different types of epidermal nevi?
Epidermal nevi are categorized based on their clinical features, by the site of occurrence and their extent of spread. However, mostly they are categorized based on the epidermal cell that predominates in the lesion. In certain patients, multiple epidermal nevi occur along with systemic abnormalities, and they form the epidermal nevus syndromes. Based on the occurrence patterns, epidermal nevi are categorized differently despite the similarity in their microscopic appearance. Nevus varicosus occurs as a single or multiple lesions, but always localized. Nevus urineus laterus occurs as a linear pattern of lesions. Ichthyosis hystrix are generalized lesions. However, epidermal nevi are also classified by their cell of origin. Nevus sebaceous are quite common and are made up of sebaceous glands with or without hair follicles. They're found commonly on the scalp, but also on the extremities or trunk, and are pale yellow in color, with a smooth, hairless surface. They are present in infants, though they may manifest only after puberty or in childhood. 1/4 of the cases eventually give rise to tumors and are mostly benign. Often it is connected with the occurrence of Schimmelpenning syndrome, phacomatosis, pigmentokeratotica, didymos-aplastic sebacea, and scalp syndrome. Keratinocytic epidermal nevus are also called non-organite epidermal nevi and are quite common among this group of lesions. They follow the lines of Blaschko and begin as brownish macules, thicken and darken with age to become plaques. They may be defined as linear or varicose based on their appearance. Other variants include the epidermolytic epidermal nevus, the acantholytic epidermal nevus, and the systemized epidermal nevus. Nevus comedonicus are formed of proliferated dilated keratinized follicles, often inflamed or showing signs of infection as a result of blockage, forming blackheads, and pitting is often seen. It may be associated with brain abnormalities, bone defects, and cataracts. The Angora hair nevus is remarkable for the long and soft white hair, like Angora wool, that grows from it. It may be associated with other defects of the brain and bones. The Becker nevus is a dark patch of hairy skin that appears like a checkerboard shape, becoming larger and darker after puberty due to androgen-dependent nature. Often it is found on the upper part of the back or on the shoulders. It is linked with other skeletal-muscular defects, forming the Becker nevus syndrome. Inflammatory linear varicose epidermal nevus is linear and forms plaques, usually unilateral. They are usually pruritic and appear inflamed and hyperkeratotic. The first appearance is after 6 months of age. Porokeratotic eccrine nevus appears as warty keratotic papular lesions, mostly on the palms and soles, but in some cases they may appear all over the skin.
Look at Extract 2. Extract 2, questions 37 to 42. You hear an interview with an ophthalmologist called Dr. Marcus Kane, who's talking about age-related macular degeneration, AMD. You now have 90 seconds to read questions 37 to 42.
My guest today is Dr. Marcus Kane, who's an ophthalmologist specializing in age-related macular degeneration, or AMD. Dr. Kane, this is a very common cause of visual impairment in older people, isn't it?
That's right. It's the most common cause of irreversible sight loss in Europe. The macula at the back of the retina typically begins to suffer damage from the age of 50 onwards. It affects straight ahead rather than peripheral vision. In the early stages, a patient may notice problems adjusting from dark to bright lights. Then, as it becomes more severe, serious blurring occurs, so patients can't make out faces, for example. And that can be traumatizing. Indeed, the results can be devastating. What seems particularly cruel is that it prevents people from doing things they take great pleasure in, like reading, watching TV, and doing crosswords. What's called dry AMD accounts for 95% of all cases. Wet AMD is less common but more disabling because abnormal blood vessels grow under the center of the retina, then leak and bleed.
Could you tell us about a typical AMD patient of yours?
Sure, I'll call her Laura. About 15 years ago, Laura felt something in her left eye, but did nothing about it for several months, even though her mother had been virtually blind towards the end of her life. Eventually, during a routine eye test, an optician suggested Laura saw an ophthalmologist. Within a week, she'd been diagnosed with dry AMD in her right eye and wet AMD in the other. She was already almost blind in her left eye. In my experience, this sort of thing's very common. AMD affects one eye badly first, but in many instances it goes unnoticed because the other eye functions. 15 years ago, there was no treatment for AMD, and Laura's right eye eventually weakened too, so she's now registered as blind.
So these days, I believe diagnosis involves an OCT scanner?
That's right. Ophthalmologists have long favored OCT, which is optical coherence tomography. It's a scanning process using light waves. Until recently, the problem with this has been the cost of the equipment, but handheld OCTs have now become available, and they're less costly, and it's claimed that these make the diagnosis of eye disease accessible to everyone. But this is dangerously misleading. The device may be simple to operate, but you need trained professionals to interpret the results. Another diagnostic tool is the use of eye drops. These enable specialists to get a better view of the retina through a special magnifying lens. A fluorescein angiogram, where a dye is injected in the arm, may also be used. This shows up any leaking blood vessels in the eye, but there can be adverse reactions, including nausea and allergic reactions.
How are patients with AMD treated?
Until about 10 years ago, there was no treatment. But now regular injections of drugs, the so-called anti-VEGFs, can suppress the protein which triggers rogue vessel formation and leakage. These drugs are injected into the eye. About a third of patients find they can see substantially better as a result, but even more striking is that in about 95% of cases, the condition doesn't deteriorate. The drawback is that the drugs only last 1 or 2 months, and patients need frequent injections over long periods of time.
Tell us about the home monitoring trial you're involved in.
Leakage reactivates in about 30% of people. They need to be monitored, which currently means visiting a hospital. The idea of the trial is that patients regularly test their own vision in the comfort of their own homes. There's a paper-based test and 2 tests using electronic devices. Some patients are apprehensive about using the electronic devices. That's not surprising given their age, and because looking at paper and small screens is a struggle if you have AMD, the people chosen for the study have some way to go before they reach advanced AMD. The point is to detect problems early. The hope is that if these tests can be rolled out as standard, it'll free up time so we can concentrate on improving treatment rather than on monitoring patients.
What about stem cell treatments for AMD?
Well, pioneering operations were recently carried out on 2 elderly patients who'd lost their sight due to AMD. Stem cell patches were used to repair the membrane at the back of the eye. Within a year of the operation, both patients were able to read again. The story was seized upon by the press, of course. Stem cell replacement was even hailed as a cure for blindness. But certain details were conveniently left out in all the hype. For example, one of the patients had type 2 diabetes, and that was exacerbated, and neither patient actually achieved perfect vision. The idea of stem cell treatment is appealing, but the suggestion that it could become an off-the-shelf treatment within the next few years seems overly optimistic.
I wonder, how head injury can lead to a condition like this?
I realize your anxiety. Definitely, I will help you to sort it out. But before moving further, would it be okay if I can ask you some questions?